Sites 8-1. Should we? Till we finish the introduction, till then other teams can log in.
Yeah, we are live now on YouTube. Okay, you can go ahead.
Okay. So good evening, friends. So welcome again to the 1 minute, please. Okay. 1 minute. Small window. Okay, let's move. So good evening, friends, and welcome to this Big Q, which is a initiative by Brain Teaser team. This is it today in association with Ophthalmological Society of Nagpur. So this is the third season of Big Q, which is an exclusive All India postgraduate quiz. And here is the famous and I've been playing for last 5 years. Brain Teaser, which began as an online platform for online quizzing for the general ophthalmologist, now has an exclusive one for Yes, and we are thankful, of course, this initiative is possible because of a strong sponsors like Micro Labs. And this is a small ad. So good evening, friends, and my pranam to all the mentors. The Brain Teaser team welcomes all to the second episode of this third season of Big Q. Brain Teaser, which was an online platform for hosting quiz for all ophthalmologists of our country since last 5 years, is now with the new initiative exclusive quiz for all India postgraduates across the country. Since last 2 years, for the first time in our country, we initiated an exclusive quiz for postgraduates with the aim of getting all the postgraduates from across the country on a single platform. There are approximately 320 institutions offering postgraduation in ophthalmology, be it MS or DNB. The first season was done in association with Bombay Ophthalmological Society, and we had the participation of around 200 teams. The last season, that was season 2, it was a participation of more than 680 teams. And so here we are back, buoyed by the success of previous 2 seasons with the third season. And this is again being done in association with Ophthalmological Society of Nagpur, and I'm thankful to the executives of the same. Remember, the third season has 8 preliminary rounds. Then we will have 4 quarterfinals, then 2 semifinals and 1 final. So that means in total 15 episodes. This episode will be aired on alternate Wednesdays at around 8 p.m. Brain Teaser is extremely thankful to the teams of quiz masters who have toiled hard to create a wonderful experience of learning with fun. Today's episode, we have some new quiz masters along with the few who have been associated with us even in last seasons. We welcome Dr. Vikas Mittal, who is currently a medical director at IJ Institute, Ambala, Haryana. He is an eminent cornea surgeon. Then we have the youngest of today's quiz master, Dr. Sonali Sontake, who is a senior resident from MGM Medical College and Hospital, Navi Mumbai. Dr. Tamonash Basu, who is a glaucoma consultant at Netralayam Super Speciality Eye Care Center, Kolkata. Dr. Anita Venugopal, who is the head of the Department of Cornea, Ocular Surface and Refractive Surgery at Arvind Eye Hospital, Tirunelveli. And of course, a dear friend of mine, Dr. Rupak Kanti Bishwas, who is a senior vitreoretinal surgeon and still an avid quiz master and follows and also quizzes. And he's a director of Netralayam, Kolkata. Thank you, each one of you, and thank you for all the efforts you have taken for these young students. Money maketh the mayor go is an old saying. Such a mega project is not possible without a strong financial aid from pharma, of course. Microvision has been our steadfast partner since last 3 seasons. My sincere most gratitude goes to Mr. Ashok, Mr. Kumar and Mr. Nautni for their untiring support and pushing us to, and in fact, they were the persons who pushed us to start this season a bit early. I would also fail in my duties if I don't acknowledge the force of Microvision, who made so many efforts to enroll all the postgraduates from across the country. Smooth and flawless execution of this Brain Teaser platform, all registrations, live quizzing, computing results, and other all back-end work is possible and is taken care of by Numeratech team. And my sincere most thanks to Mr. Sai and his team. Now it's time for me to hand over the screen to my colleague, Dr. Shilpi Narnore, who is the co-host of this program, to familiarize all the participants with the rules of the game. Over to you, Dr. Shilpi.
So good evening, friends. Welcome back. So quickly, we'll see the rules again for the new participants. So yes, this is season 3, which will be conducted on the alternate Wednesdays at 8 p.m. Platform will be Kahoot for both the teams and the non-PG participants. There will be total 15 episodes. Out of these 15, 8 will be the preliminary rounds, 4 quarterfinals, 2 semifinals, and 1 final. So out of the 8 preliminary rounds, total of the best 5 performances will be calculated for you to be qualified for the quarterfinal round. And today's is the second episode. So you still have time. You have 6 more episodes after this episode. So for the quarterfinals, 80 teams will be selected. And out of these 80 teams, 20 teams will play the semifinals and 10 teams will make into the finals. So we have 2 platforms. One is Kahoot and one is Zoom. Every team needs to log in from the 2 devices. First screen is the Zoom platform for the live quizzing and to monitor the teams. All video should be on, but their audio should be off. While the second screen will be the Kahoot to answer the questions. Mentors to log in from the separate screen only on the Zoom platform. So in today's episode, there are 10 sets. Each set has 5 questions. You will get 10 seconds per question to answer. There will be no negative marking. So the computation will depend upon the fastest finger first. So these are the big prizes which will be given to the PGs during the finals. Mentors will also get the prizes, while the audience prizes will be per episode. So now with this, this is the sample question for your understanding so that you can check your Kahoot platform, your buttons and everything.
बैल जैसे धूल उड़ा के सींग उठा के तुम भी नाचो, बाजे जम के ताल ढोल, बेटा राजू उड़ के नाचो।
हीरो से भी तेज कोई कर सके जो बेद नाचो।
अस्तबल में घोड़े जैसे भाग डोर छोड़ नाचो। मिट्टी जो रोट मोटा मिर्चा खा के ऐसे नाचो। हाँ जा छोरे,
हाँ जगोरे,
हाँ जा छोरे, नाचो 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 वीर नाचो, नाचो 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 नाचो।
So this is a sample question and marks will not be calculated. So the question is, who currently lives in the building you see in this background song? Vladimir Putin, B is Zelensky, C is Macron, and D is Governor of Karnataka. And your time starts now. Yes. So the answer is option B. That is Zelensky. So this was a sample question. Now we will move towards the final question round of the MCQs. Now I invite our first quiz master, Dr. Tamunash Basu, who is a consultant at Netralim Super Speciality Eye Care Center, Kolkata. His specialization is in glaucoma, cataract, and anterior segment diseases. There are many numerous publications to his credit in the national and international journals, and he has presented multiple papers and posters in several national and state conferences. So over to you, Basu sir.
Thank you so much, Shilpi ma'am, and Prashant sir, for giving me the opportunity. Can I have the questions like? So what does the word A stand for in A scan? The options are A, attenuation, B, acceleration, C, amplitude, and D, augmented. The time starts now. So the answer of the question is the A of A scan stands like the word A means amplitude. So what happens in A scan? There is a single sound beam which is sent from the transducer, and the echoes returning from different structures. They give spikes, and the height or the amplitude of the spikes gives us is the proportional to the strength of the echo. So how dense is the structure? That is known from the amplitude. So that's why the A or amplitude scan, the A scan comes from. Okay. So the next question. All of the following cricketers have suffered eye injuries on the cricket field except A, Sabah Karim, B, Mark Boucher, C, Craig Kisweta, D, Mansoor Ali Khan Pataudi. Remember, all of the following cricketers who have suffered eye injuries in the cricket field, except these are the options. Your time starts now. Okay, the answer is D, Mansoor Ali Khan Pataudi. He lost one eye in a car accident. Others lost in during cricket field. In the cricket field, Sabah Karim and Craig Kisweta like had an eye injury while batting, and Mark Boucher had an injury with bail while he was stamping, while he was keeping actually. Next question. So you have to identify the legend in the picture of this legend in the field of ophthalmology. The options are A, Alvar Gullstrand, B, Charles Spence, C, Edward Zarm, D, Hermann von Helmholtz. The time starts now. So the answer is D, Hermann von Helmholtz. Helmholtz was a physician and a physicist he invented the ophthalmoscope, and also he was a physician. He had a immense contribution in the field of acoustics and aesthetics. He had a theory of vision also and color vision also. So in ophthalmology also, he had a huge, immense impact. But main thing is he invented the ophthalmoscope. That was a picture of Hermann von Helmholtz. Next question. So the next question is maximum contribution of the refractive power of the eye is by which part of the eye? A, anterior surface of cornea. B, posterior surface of cornea. C, posterior surface of lens. Or D, anterior surface of lens. Your time starts now. Okay, the answer is maximum contribution of the refractive power of the eye is by anterior surface of the cornea. This is more around 48 to 50 diopter, and this is because of the large difference of indices of refraction between the air and the cornea. So the anterior corneal surface contributes the maximum. The next question, Roquefort trial. This is the name of the trial. Roquefort trial was done between which two molecules? Option A, ripasudil versus timolol maleate. B, latanoprostone bunod versus timolol maleate. Or C, netasudil versus timolol maleate. Or D, bimatoprost versus timolol maleate. Your time starts now. Okay, the answer is Roquefort trial is netasudil, which is a ROCK inhibitor, versus timolol maleate. It is a non-inferiority trial, means once daily dosage of netasudil is non-inferior to the twice daily dosage of timolol maleate. This study is Roquefort trial. Okay. So for the next segment, I would like to invite Dr. Sonali Sontake. She has done her MBBS from Padma Shri Dr. D.Y. Patel Medical College, Navi Mumbai. She has done her MS Ophthalmology and FCPS Ophthalmology from Bombay Hospital Institute of Medical Sciences, Mumbai. And she was a ex senior resident in Topiola National Medical College and BYL Nair Charitable Hospital, Mumbai. And currently working as a senior resident in MGM Medical College Hospital, Navi Mumbai. Over to you, Dr. Sonali Sontake.
Thank you so much, Dr. Basu. So we move ahead to the next segment, the next questions. Can we see the question on the screen, please? So, which gland does not contribute to the aqueous layer of the tear film? The options are: which gland does not contribute to the aqueous layer of the tear film? Can we see the options, please?
Yes, it's been shared.
I can see only one option on my screen.
So you have to tell the options.
Okay. Cross glands, main lacrimal glands, Zeiss glands, and Wolfram glands. So our timer starts now. Time is up. And the right answer is Zeiss glands. Okay. So tear film has got 3 layers: lipid layer, aqueous layer, and mucus layer. The lipid layer is formed by lipid released by meibomian glands, Zeiss glands, and hair follicle. Aqueous is produced by lacrimal glands and accessory lacrimal glands, that is Krauss and Wolfram. And the mucus layer is produced by the goblet cells. So the correct answer was Zeiss glands here. So we move on to the next question, please. So which surgical method would be the most appropriate for reconstruction of the posterior lamella? Which surgical method would be the most appropriate for reconstruction of the posterior lamella? The options are: A, Cutler bed flap; B, bipedicle myocutaneous flap, option C, full thickness skin graft, and option D, Hughes tarsoconjunctival flap. So we begin the timer for this. Time is up. And the correct answer for this question is Hughes tarsoconjunctival flap, option D. So neither a bipedicle myocutaneous flap nor a full thickness skin graft adequately replaces the posterior lamella tarsal plate. The Hughes tarsoconjunctival flap transposes a bridge flap of tarsus and conjunctiva into the defect. A full thickness skin graft or advancement flap is used to replace the anterior lamella, and a Cutler-Baird flap is a reconstructive technique that replaces full thickness defects of the upper eyelid with full thickness tissue flap from the lower eyelid on the same side. Okay, so we move on to the next question now. How long does it take a photoreceptor to renew its outer segment? How long does it take a photoreceptor to renew its outer segment? The options are 10 seconds, 10 minutes, 10 days, or 10 hours. So we begin the timer now. Time is up. So the correct answer is option C, 10 days. It takes 10 days for the photoreceptor to renew its outer segment. The very important function of RPE is phagocytosis of the outer segment of the photoreceptor, and each photoreceptor renews its outer segment every 10 days. Okay, we move ahead to the next question. All are true about golden heart syndrome except option A, iris colobomas may be present. Option B, upper lid colobomas may be present. Option C, periauricular skin tags may be present. Or option D, it can have an autosomal dominant inheritance. So our timer begins now. Time is up. So the correct option is iris colobomas may be present. Option A. Okay, so what is golden heart syndrome? It is a sporadic or an autosomal dominant inherited syndrome of the first branchial arch. It consists of a triad which has epibulbar dermoids, facial anomalies such as upper eyelid colobomas, preauricular skin tags, and oral fistulas, and skeletal abnormalities. So we do not see iris colobomas in golden heart syndrome. Okay, we move to the next question. Which one of the following characteristics regarding serpiginous choroidopathy is true? Options are A, it primarily affects children. Option B, there are multifocal lesions. Option C, it has a recurrent and indolent course. And option D, it responds promptly to corticosteroids. So the timer starts now. Time is up. And the correct answer is option C, recurrent and indolent course. So what is serpiginous choroidopathy? It is a geographic helicoid peripapillary choroidopathy. It is chronic recurrent indolent disease of unknown etiology. It affects the adults and not children, and there is painless loss of vision. The lesions are peripapillary or perimacular and have inflammation along the edges in the active phase. There is centrifugal spread in a snake line-like pattern over months to years. And you treat with steroids or immunosuppressive agents, there will be variable success. And you always have to exclude TB before you start anti-inflammatory therapy. Okay, so we move on to the next segment. I would like to invite Dr. Anita Venugopal, Madam, for the next segment. She has done her post-graduation from AEH Tirunelveli. She is HOD of Cornea, Ocular Surface and Refractive Surgery at Arvind Eye Hospital, Tirunelveli. She is in charge of the Rotary Arvind Eye Bank, Tirunelveli. She is a high-volume phaco surgeon. Her areas of interest are ocular surface reconstructions and keratoconus. She has received Best Silver Award from IJO in 2022, Best Video Award in 2021, and she has done 22 cases of orokeratoprosthesis since 2012 and published results in Cornea Journal 2016. She works with Intralaser platform since 2014 and has guided PGs, done her thesis with her PGs, trained 29 fellows since 2012 and has published 75 articles in both national and international journals. So we welcome Dr. Anita Venugopal, Madam.
Thank you, Sonali, for the kind intro. Thank you, Prashant sir and Shilpi for having me here in this big Q platform. So let's start with the first question of section 3. Blood vessels in trachomatis pannus. They lie, option A, beneath the Tesmets membrane. Option B, in the substantia propria. Option C, between Bowman's membrane and substantia propria. Option D, between Bowman's membrane and epithelium. The timer starts now. So the correct answer is the blood vessels in trachomatis pannus lie between the Bowman's membrane and epithelium. Trachoma is a chronic infectious keratoconjunctivitis caused by Chlamydia trachomatis. The conjunctival involvement is more than the corneal involvement, and it starts with follicular conjunctivitis and then progresses to superficial keratitis and then corneal vascularization, leading to scarring. The vascular pannus is typical and it consists of new vessels and connective tissue. They lie between epithelium and Bowman's membrane. In severe cases, it even replaces the Bowman's membrane. The second question, please. So identify the true statement among the following. A. Cornea is exclusively innervated by type B and D nerve fibers. Option B. Density of nociceptors in the cornea is estimated to be 300 to 600 times that of the skin. Option C. Density of nociceptors are 20 to 40 times less innervated than that of tooth pulp. Option D. The corneal nerves are organized into 5 layers. The timer starts. The correct answer? The true statement among the following is the density of nociceptors in the cornea is estimated to be 300 to 600 times that of the skin. Cornea is a densely innervated tissue, very sensitive tissue, and innervation is derived from ophthalmic division of trigeminal nerve. This provides cornea with a large number of sensory receptors such as myelinated A alpha and unmyelinated C fibers with 7,000 free nerve endings per square millimeter, which is 300 to 600 times greater than that of the skin and 20 to 40 times that of the tooth pulp. So sensitive. The next question, please. Which among the following is the true ectatic disorder? Option A, pellucid marginal degeneration. Option B, keratoglobus. Option C, keratoconus globus type. Option D, all of the above. The timer starts now. So the correct answer, keratoglobus. Why? The explanation follows. Ectasia denotes increased surface area and thinning. The normal mean corneal surface area is 120.3 millimeters square. And keratoconus exhibits no change in the corneal surface area. So the mean surface area that is noted in many of the literatures are only 116.2 millimeter square. And keratoglobus is a true ectasia with increase in the surface area and diffuse thinning, 129.9 millimeter square. The next question. Question number 4. Describe McReynolds technique of pterygium excision. Option A, excision followed by suturing the head of the pterygium to the body. Option B, excision followed by suturing the head to the inferior fornix. Option C, excision followed by leaving the bare sclera. Option D, none of the above. So the correct answer, McReynolds technique is nothing but excision followed by suturing the head of the pterygium to the body. So there are many different techniques were described to reduce the recurrence of pterygium, growth of the pterygium by many corneal surgeons from very beginning of 1939. This method, McReynolds method, was suggested by Duweger and Welter in 1939. It's an older technique proposed to reduce the recurrence. And the bare sclera technique is also called as McGavick's technique. And another technique which was mentioned in the quiz, head of the pterygium sutured to the inferior fornix, that is called as Kerr's technique. The next question, the last one. So following instruments are projection-based evaluation of corneal curvature, except option A, rasterostereography, option B, laser interferometry, option C, video keratography, option D, Mori interferometry. The timer starts now. Very easy one. The correct answer, video keratography. So projection-based corneal topographer measures the shape of the cornea by projecting an image onto the cornea and analyzing the reflection. The image is projected in the same way as a slide onto the screen. Projection-based corneal topographers use different techniques like slit photography, rasterostereography, laser interferometry, and Moro interference. Video keratograph is a reflection-based one. Here, the reflection is either viewed directly or by a camera attached to the computer. Thank you. Let me welcome Dr. Rupak Kanti Biswa sir. He is a senior VR surgeon and director, Netralayam, Kolkata, the first surgeon in India to perform retinal transplant surgery and first surgeon to perform ROP surgeries in Kolkata. He has performed more than 10,000 complicated retinal surgeries and established multiple new VR units in different hospitals in Eastern India. Sir is the recipient of Red Buckler Award from ASRS, Best Film Award from Uretina, FIFA Award from AOS, Best Innovation Award from EI ZOC, at State Society, multiple awards and Best Video and KP Roy Awards. And Sir has presented in more than 100 national and international podium presentations, 14 publications in peer-reviewed journals, and currently, Sir is the chairman, Scientific Committee OSWB, and overseas consultant, Machine Development of Ortelli, Switzerland. Over to you, sir.
Yeah. Good evening to all the participants, and I'd like to thank the whole, Brain Teaser team, Dr. Prashant and Dr. Shilpi. And let's start with our quiz directly. The first question: which of the following drug may cause cystoid macular edema, except your choices are topical latanoprost, B, tamoxifen, C, glitazone, and D, interferon alpha. And your time starts now. And the answer is interferon alpha. In fact, you all know that rest they can produce a kind of a cystoid macular edema, rather topical interferon we do use for the uveitic refractory macular edema. So it actually is being used for the treatment of macular edema. Next. Which hypersensitivity reaction is most likely to be implicated in phacoanaphylactic glaucoma? Your choices are type 1, type 2, type 3, and type 4. And your time starts now. And the answer is the type 4. In fact, though it is known as phacoanaphylactic, but it is actually is mainly the Arthur's type immunocomplex mediated, which is IgG and complex system to engulf that lens protein and then causing this phacoanaphylactic glaucoma. Next. Which visual field defect is most likely to occur in non-arthritic ischemic optic neuropathy? The choices are altitudinal field defect, B, central field defect, C, hemianopic field defect, and D is enlarged blind spot. And the answer is altitudinal field defect, because here, because of the the supply of the in blood circulation, so once the one half of the semi half is getting affected for that, most of the time it is the inferior half which is got affected most of the time. So you get the either superior or inferior altitudinal defect. Next. The following findings are true in chronic rhegmatogenous retinal detachment except. So that means which one is false out of 4 options? A, absolute field defect, B, demarcation lines, C, retinal cyst, and D, neovascular glaucoma. Your time starts now. Yes, the answer is A. Here you won't get an absolute field defect usually, and which is more common in retinoschisis. Next. So the normal base in fusional reserve for the distance R, what is the range of fusional reserve? 5 to 10 prism diopter. Number B, 15 to 20 prism diopter. Number C, 25 to 30. And number D, 35 to 40 prism diopter. Your time starts now. Yeah, this is a database question, so it is 5 to 10 prism diopter. Is a normal base in abduction, which you can manage by the normal bus. Next, I'm going to introduce Dr. Vikas Mittal. Actually, Dr. Vikas is a very good friend of mine, and he is medical director of LGI Institute, Ambala, Haryana. He is a par excellence corneal surgeon, and he did his cornea fellowship from LV Prasad Eye Institute, Hyderabad. His special interest is endothelial keratoplasty, keratoconus, and refractive surgery. He is mentor for cornea fellowship program at LGI Institute. He has more than 40 publications in index journal and more than 200 national and international presentations all over the world. Vikas is on you now.
Thank you so much, Dr. Rupert. Thank you so much. It's lovely to see you also after a long time. And
Yeah.
thank you so much. This big Q, Dr. Prashant, Shilpi, you guys are doing an amazing thing. And I was fortunate to be associated in the last season also. I thoroughly enjoyed it. And best of luck, best wishes to all of you who are participating. So I think without wasting any time, let's go ahead with the question.
Vikas sir,
Can we have,
yes, sir. Wait a minute, sir.
yes,
Kahoot is not working
Madam, it is working.
because everyone is putting in the group that it is failing to
Let us
connect.
check the next question, madam. I think there is,
Sure.
there would not be a pause, but it is working.
Yeah. Okay.
so we want to start?
Yes, sir.
Okay, so let's go ahead with your next question. We have already talked about keratoconus. There's another question on keratoconus now. So keratoconus has got association with one of the following conjunctival condition. Okay, keratoconus and which conjunctival condition? So here are your options. Option A, follicular conjunctivitis. Option B, subconjunctival hemorrhage. Option C, membranous conjunctivitis, or option D, vernal keratoconjunctivitis or VKC. Your time starts now. Keratoconus and what of these conditions?
I didn't catch that. Could you try again?
Okay, the right answer is, you got it right, VKC. And we all know that when the patient of keratoconus comes, what advice we give? We tell them, don't rub your eyes. So rubbing, inflammation, and then biomechanical weakening of cornea, these are the serial, and that's why we get keratoconus. Okay, so let's go on question number 2 of this section. What type of corneal dystrophy is associated with acid mucopolysaccharidosis? Corneal dystrophy and mucopolysaccharidosis. Your options are option A, granular corneal dystrophy, option B, lattice corneal dystrophy, option C, macular dystrophy, or option D, peripheral dystrophy. Your time starts now. Acid mucopolysaccharidosis and which corneal dystrophy? Okay, time up. So here's the right answer. The right answer is macular corneal dystrophy. So this is how this macular corneal dystrophy looks like. There are deposits and intervening stroma is hazy, while in granular dystrophy, intervening stroma is clear. And these deposits, these GAG deposits, they are in Bowman, Desmet, endothelium, all over. So and you get a thinning of cornea. So suppose you have a doubt, you do a pachymetry and the pachymetry is less, the chances are that it's a macular corneal dystrophy. Okay, let's go ahead with our next question.
Can you stop
So
for
question
a
is,
moment? Sorry to interrupt. Can you stop for a moment, doctor? There are queries on the WhatsApp saying they are not able to join. I'll
Yes,
resolve.
exactly. That's what I'm saying.
we can wait, no problem. We can wait.
Participants, if you're not able to join with the same ID, it's not a problem. Just change the last character to something different and you'll be able to join. Use the same mobile number, use the same prefix, either PG or PP. The last team name, you change the last character alone. One character and you'll be able to join. There had been a pause in Kahoot, but you can still resume. Please change the last character alone. If you had to use a different device or if your name has changed, please send a message on WhatsApp. We'll take that into consideration.
So guys, take it easy and do as he's saying. And Dr. Prashant and Dr. Shilpi are very kind, so don't worry.
See, I know everyone is messaging that score has become 0. We have all the data, so don't worry. Re-log in. If it is not taking the same name, just make it a caps lock or keep the phone number same. Just change the initials or the last thing. We will take into the consideration all the previous marks and again when you are logging in. Okay? So I think now it's working. We'll restart the game.
Yes, and no worries, as she's saying that, they all those the number that 0 and all marks, they already have all the records. Don't worry at all. So focus on your next question now. So here we go. The normal cornea has normal cornea. Okay, let's see what are your options. Option A, abundant blood vessels seen only with high mag. Option B, rich sensory innervation. Option C, ability to regenerate Bowman membrane. And option D, none of above. Normal cornea has abundant vessels, rich sensory innervation, able to regenerate Bowman layer, or none. Your time starts now. Very simple question, no? Time up. I'm sure you've got it right. The normal cornea has rich sensory innervation. So I've got a pencil, so I can touch it on my skin, but I can't touch it on my cornea. So the sensitivity will be 400 times. Isn't it great? Okay, let's go with the next question. Next question is, following is not used for cautery of corneal ulcer. Following is not used for cautery of corneal ulcer. Here are your options. Option A, trichloroacetic acid. Option B, iodine. Option C, carbolic acid. Or option D, mercurochrome, which is not used for cautery of corneal ulcer. Your time starts now. Time up. Slightly theoretical question. The correct answer is mercurochrome. So although these days we rarely do this cautery of ulcers, but it's mainly theoretical question. But mercurochrome has mercury, and that's why it should not be used. Okay, let's go ahead with our next question. Salmon patches. Salmon patches are seen in. Okay, the options are hemorrhage into the cornea. Option B, interstitial keratitis. Option C, retinitis pigmentosa. Or option D, follicular keratitis. Your time starts now. Salmon patches. Time up. I still remember that photograph of salmon patch in Kansky. Okay, the correct answer is interstitial keratitis. So this typically happens in syphilitic keratitis, and it has both neovessels as well as lymphatic invasion. That's why it looks like salmon colored, and it's generally in the deep stroma. Okay, let's go with the next question.
I think we are through with the section.
Oh, super.
Thank you for wonderfully conducting this last part of the first section. Okay, so now it's time for us to move ahead. And as we remember, again, just a way of thanking the sponsors who have been standing behind us steadfastly. It's the Micro Labs, a small advertisement for them. Okay, so now it's time for us to move to the second round, and the second round, the first, that is section 6, that will be the second round. First part will be played by Dr. Tamonash Basu. So Dr. Tamonash Basu, I welcome you again, and please.
So in this set of questions, in subthreshold retinal laser therapy, the subthreshold retinal laser acts on which layer of retina? The options are A, retinal pigment epithelium or RPE, B, internal limiting membrane or ILM. C, ganglion cell complex or GCC. D, retinal nerve fiber layer or RNFL. Your time starts now. Okay, the answer of the question is retinal pigment epithelium. So subretinal threshold laser or pattern scanning laser or Pascal or micropulse laser, these are semi-automated multiple short pulse of laser, and they act on RPE layers, inducing a thermal stress and activating a cascade of events. Next question. So you have to identify this instrument. So is it a keratometer? A, keratometer. B, direct ophthalmoscope. C, slit lamp. D, ophthalmotrope. Your time starts now. Okay, and the answer is this is the first slit lamp. It is invented by Alvar Goldstand, and for this invention, he won the Nobel Prize in 1911. This is the first slit lamp picture. Okay, the next question. So, which of the following conditions can cause hypotonous maculopathy? A, suprachoroidal hemorrhage. B, cyclodialysis cleft. C, choroidal effusion. Or D, Bleblich post-filtration surgery. So your time starts now. Okay, the answer is obviously suprachoroidal hemorrhage. In suprachoroidal hemorrhage, we get normal to high intraocular pressure, whereas in other conditions, it's all hypotonous state and can lead to hypotonous maculopathy. So identify this instrument. This is a prototype instrument. Identify this instrument. Is it a Jabal-Schwartz keratometer? Or B, Babbage ophthalmoscope? Or C, Lister perimeter? Or D, Maklakoff tonometer? Okay, this is a prototype picture, and the answer is Lister perimeter. This is a prototype picture of Lister perimeter. It has a record of 90 degrees. It's a kinetic perimeter. It has a mark at 90 degree all around. It can be rotated, and it's a kinetic perimeter. It moves, and where it moves, you can see first. You can like denote actually. So it's a prototype Lister perimeter. The picture is prototype Lister perimeter. Next question. So this is a historical procedure. What procedure is being performed in this picture? The options are A, diode CPC, B, iodine classes, C, cyclodialysis cleft repair, or D, goniotomy. Your time starts now. Okay, the procedure here is iodine classes. This is a historic surgery. We don't perform it right now. It's a free filtering full thickness passage from anterior chamber to subconjunctival space. And there is a, you can see the iris was peeking, like the iris was peeking through the sclerostomy. It was like intentionally pulled out to prevent the scarring of that sclerostomy. So it's very like previously it was used, and there was high complication rates with this surgery. So we don't do it now, but this is iodine classes surgery. So my sets are over. I would like to request Dr. Sonali to start the next set of questions.
So we move ahead to the next section, section 7. So here are our questions. We begin. What is the best initial therapy for malignant glaucoma? The options are 2 2% pilocarpine, B. Laser iridotomy, C. Lens removal, D. Mydriatic cycloplegic therapy. So the timer starts now. Time is up. So the answer is option D, mydriatic cycloplegic therapy. So malignant glaucoma or aqueous misdirection syndrome, it occurs when the aqueous humor is secreted into and sequestered in the vitreous cavity, pushing the lens, hyaloid face, and the iris forward, thus collapsing the anterior chamber and blocking the trabecular meshwork. IOP often rises significantly and the anterior chamber becomes shallow both centrally as well as peripherally. The clinical features are shallow or flat anterior chamber, normal or increased IOP, poor response to myotics, and favorable response to cycloplegics mydriatics, which act by pulling the lens iris diaphragm posteriorly. So the correct answer is cycloplegics mydriatics. We move on to the next question. Which one is not associated with decrease in hyaluronate concentration in the vitreous humor? The options are vitritis, diabetes, phakia, myopia. So our timer starts now. The correct answer is option C, that is phakia. So there are various biochemical changes that occur in the vitreous with age and with disease. The causes of decreased concentration of hyaluronate are first synersis, then myopia, aphakia, not phakia, aphakia, diabetes, any injury with hemorrhage, inflammation or vitritis, which was the option, and surgery. So we move on to the next question. Potential late complications of ROP will include all except A. Strabismus, B. Myopia, C. Negative angle kappa, or D. Glaucoma. The timer starts now. The correct option is option C, that is negative angle kappa. So ocular complications which occur in ROP, which is either treated or untreated, could be strabismus, pseudostrabismus, high refractive error or myopia, retinal folds, macular dragging, retinal detachment, amblyopia. Stage 5 ROP can cause cataracts, glaucoma, and phthisis bulbi. And there could be peripheral anterior synechia, which cause secondary angle closure glaucoma, and positive angle kappa on examination due to temporal dragging of fovea. So the answer is negative angle kappa. The next question, which statement about retinal pigment epithelium is false? Options are RPE interdigitates with the apical processes of the rods and cone segments. Option B, RPEs are densely adherent to the Bruch's membrane. Option C, RPEs comprise the inner blood retinal barrier. And RPE cells are taller and they contain a greater concentration of pigment in the macula. So we begin the timer. Time is up. The correct option is option C. RP is comprised of the inner blood retinal barrier. This is a very easy question. RP comprises of the outer blood retinal barrier. Inner blood retinal barrier consists of the endothelium, which lines the retinal blood vessels. So the next question. Downbeat nystagmus may be a result of all of the following, except option A, normal lithium use, option B, pineoloma, option C, a paraneoplastic syndrome, option D, craniocervical junction abnormalities. So we begin the timer. The correct answer is option B, that is pineoloma. So downbeat nystagmus has been associated with both therapeutic and toxic levels of lithium, which does not resolve after stopping lithium. It has been reported as a remote effect of cancer, that is paraneoplastic cerebellar degeneration, and with gynecological malignancy and small cell CA of the lung. They are implicated most frequently. Craniocervical junction abnormalities like tumor, syrinx, Arnold-Chiari malformations can be ruled out on doing an MRI. And pineolomas or other lesions are seen in the dorsal midbrain, which result in perinode dorsal midbrain syndrome, the features of which are contraction retraction nystagmus, upgaze paralysis, and light near dissociation. So we move on to the next segment. I would like to re-invite Dr. Anita Madam for the next segment.
Thank you.
Over to you, ma'am.
The next set of questions, again on mucopolysaccharidosis, favorite of cornea surgeons. The question is, mucopolysaccharidosis associated with corneal clouding include the following, except option A, Haller syndrome, option B, She syndrome, option C, Markov syndrome type 6A and 6B, option B, Martua-Lamy syndrome type 6A and 6B. The timer starts now. It's a very common question asked in PG. So the correct answer, Markov syndrome type 6A and 6B. So it's just a number play. It is type 4 and not type 6. The next question, please. So what is Dalglish line? Option A, it is an iron line found in the patients with radial keratotomy. Option B, iron line found at the base of the cone in keratoconus. Option C, iron line found in the inferior cornea in patients with hereditary spherocytosis. Option D, it's an iron line found in the interpalpable aperture of the cornea. The timer starts now. Dalglish line. So the correct answer, Dalglish line is nothing but an iron line that is found in the inferior cornea in patients with hereditary spherocytosis. So hereditary spherocytosis is a disease characterized by altered RBC membrane integrity due to mutations in genes encoding membrane or cytoskeletal proteins. Ring-like deposits are produced as a result of intraepithelial deposition of excess of free iron. The next question, please. Corneal perforation is the ocular sequelae of untreated neonatal conjunctivitis due to option A, chlamydial conjunctivitis, option B, gonococcal conjunctivitis, option C, herpes, option D, fungal. The timer starts now. Very easy one. So the correct answer, corneal perforation in neonates is due to gonococcal conjunctivitis. So it's more severe than the chlamydial. It has an ability to penetrate intact corneal epithelium, leading to edema and ulceration, leads to perforation and end off if left untreated. The next question, please. So what is the type of cell that lines the canal of Schlemm? Option A, fenestrated monolayer of endothelial cells connected by tight junctions. Option B, non-fenestrated monolayer of epithelial cells connected by gap junctions. Option C, non-fenestrated monolayer of endothelial cells connected by tight junctions. Option D, fenestrated monolayer of endothelial cells connected by gap junctions. Timer starts now. The word play, fenestrated and gap and tight junctions. The correct answer is non-fenestrated monolayer of endothelial cells connected by tight junctions. The explanation is the canal of Schlemm. It's a ring-shaped vessel that encircles the cornea lined by endothelial cells. It's a small collecting duct that drains most of the aqueous humor in human eyes. It's covered and held open by trabecular meshwork. Endothelial monolayer lining the Schlemm's canal can be conveniently subdivided into inner and outer walls. So due to directionality of the aqueous humor flow into the Schlemm's canal, inner wall cells are distended by a basal to apical pressure gradient, whereas outer wall cells are forced against their basal lamina and do not experience this distension. The next question. The last question of this set of section. All are the substances in our tears that act to control the conjunctival flora and reduce bacterial adherence, except option A, lactoferrin, option B, lysozyme, option C, beta-lysine, option D, secretory IgA. So all are the substances in tears that act to control the conjunctival flora and reduce the bacterial adherence, except. The timer starts now. So the correct answer, beta-lysine. Tear contains immunoglobulins to prevent infections, and immunoglobulin A is present at much higher concentrations in tears than in serum, which binds to bacteria and prevents the bacterial adherence to epithelium. IgG as well as IgA can neutralize some viruses and bind to bacteria and hence play an important role in corneal defense, except beta-lysine. Thank you. So I would like to again invite Dr.
Rupak sir.
Rupak sir. Over to you, sir.
Thank you. Yeah. Thank you. And it's going on so smoothly, except the little bit of technical hitch. So we'll move on to our section 9. Which of the following peripheral retinal degeneration are associated with increased risk of rhegmatogenous retinal detachment, except number 1, lattice degeneration, number 2, retinoschisis, number 3, cystic retinal tufts, and number 4, microcystoid degeneration. Your time starts now. Yeah. So the answer is microcystoid degeneration. In fact, all of them are having an increased risk of retinal detachment, except microcystoid degeneration, which usually it is a cystoid changes in the retina, so it does not actually create a retinal hole, and that's how it is not associated with increased risk of retinal detachment. Next. Which statement is false regarding brolucizumab? Which statement is false regarding brolucizumab? Brolucizumab is the newer, anti-VEGF medications which is in use for maybe last few years. Since the molecular mass is only 29 kilodiopter. Number 2, 6 mg dose is given for neovascular AMD. Number 3, can cause intraocular inflammation. Number 4, the anti-VEGF binding capacity are 22 times greater than ranibizumab. And your time starts now. And the answer is, yeah, it's the molecular mass is the answer. Go to the next slide. So you can see it here, the different, aflibercept, ranibizumab, brolucizumab, the usual, the size of this. This is a full antibody of IgG, and it has a molecular size, though it is the smallest one. Next. Yeah. So, which is false regarding exudative retinal detachment? It has, the RD has a convex configuration. Number 2, it shows phenomenon of shifting fluid. Number 3, there is no vitreoretinal traction. And number 4, treatment of choice is partial vitrectomy. So, which one is false? Time starts now. So the answer is treatment of choice is partial vitrectomy. So only in case of rhegmatogenous retinal detachment, we do treat for this partial vitrectomy is a treatment of choice when you have a rhegma or the break. Here it is an exudation which is occurring behind the retina, and that's how the bullous retinal detachment occurs, and you have the convex configuration with a shifting fluid. Next. Which statement is false about full thickness macular hole? I am sure you all have come across with this kind of full thickness macular hole in OCT. The hole form factor of more than 0.9 shows higher rate of closure. So that means higher hole form factor is higher closure rate. Number B, it has spontaneous closure rate of 40%. Number 3, treatment is vitrectomy with ILM peeling and tamponade. And number 4, most common cause is idiopathic. Your time starts now. So the answer is, it has a spontaneous closure rate of 40%. Usually, normally, the spontaneous closure rate of our idiopathic macular hole ranges on almost near about 2 to 3% only. 40% chance is in case of traumatic macular hole. Next. Following is the best treatment option for the condition here explained here. So here you can see this color fundus photograph and the OCT. Let me explain it, and the OCT and this fluorescein angiogram, which is showing there is a neovascular condition. You can see neovascularization elsewhere is here. You have associated macular edema also, and this is a diabetic retinopathy, proliferative diabetic retinopathy, along with CSME. So the treatment options are, best option for the treatment are panretinal photocoagulation. Number B, anti-VEGF therapy plus panretinal photocoagulation. Number C is vitrectomy. And number D, observation and control, tight control of the blood sugar level. Time starts now. So the best treatment answer is number B, whereas anti-VEGF plus PRP, panretinal photocoagulation, because here you have the macular edema, which is going to worsen if we do only panretinal photocoagulation. So if we treat it with anti-VEGF followed by panretinal photocoagulation, both the macular edema and the proliferation is being taken care. So the combination of anti-VEGF followed by pan-retinal photocoagulation would be the best treatment option. So now next session by again Dr. Vikas. Over to you, Dr. Vikas.
Thanks so much, Dr. Rupak. And hello, everyone. I'm back. And if you have some water bottle nearby, please take a sip of water. Take some chocolates, take a break also. Great. So we are going to have our last section, I think, and I'm sure these will be comparatively easier questions. So if you are all set, let's go ahead on our section 10. Please, can I have our next question, please? ARMD. So if I'm a cornea surgeon, that doesn't mean that I can't ask a question on retina. So age-related macular degeneration is responsible for which type of visual field defect? You must know that where it is actually, where is the main pathology. ARMD is responsible for which type of visual field defects? Your options are A, central, B, peripheral, C, bitemporal hemianopia, or D, binasal hemianopia. Your time starts now. ARMD. Which type of visual field defect? Time up. I think it is comparatively simple question. So the correct answer is yes, A, central visual field defect, because it affects bang in the macula, so there will be central scotoma in ARMD. So let's have our next question, please. Name the condition with clear irrigation but no fluorescence leak into the nose. So from retina to oculoplasty. Name the condition with clear irrigation but no fluorescent leak. Option A, normal lacrimal passage. Option B, blockage of lacrimal passage. Option C, upper canalicular block. Or option D, lower canalicular block. Which among these is a condition where there's a clear irrigation but no fluorescence leak? Can we have the timer, please? Okay, time up. The correct answer is C, upper canalicular block. This is nothing but negative secondary zone test. That's all I know about it. So let's go to the next question. Earliest sign of siderosis bulbi. Which is the earliest sign? A, rusty deposits in the subcapsular epithelium. B, Fischer ring. C, pigmentary retinopathy. Or D, red-brown staining of iris. Your time starts now. Earliest sign of siderosis bulbi. Okay, time up. The correct answer is A, rusty deposits in the subcapsular epithelium. Siderosis bulbi, as we know, it's because of retained intraocular foreign body, mainly iron, and you can see, because of the iron deposition or direct trauma to the lens, these dark deposits, you can see it just under the capsule. Okay, let's have our next question on the screen now. Treatment of photoophthalmia. Okay, what's the treatment? Here are your options. Option A, atropine. Option B, steroids. Option C, dark goggles. Or option D, patching and reassurance. Your time starts now. Treatment of photoophthalmia. Time up. The correct answer is just reassurance, lubricants, or maybe patching. What is photoophthalmia? Excessive UV light exposure. And you have some, mild symptoms which generally gets over in a couple of days. Okay, let's go on to our next question. So this question is, a patient complains of maceration of skin of the lids and conjunctival redness at the inner and outer canthi. Inner and outer canthi. Conjunctival swab is expected to show, and the options are A. Staph aureus, B. Streptoviridens, C. Pneumococcus, or D. Morex Exenfield diplobacilli. Your time starts now. Only at the inner and outer canthi. Time up. The correct answer is yes. D. Morex Exenfield diplobacilli. There's nothing but angular. Can we have a next slide, please? This is nothing but angular conjunctivitis. It's rare, but in quiz you need to know all those rare things also. Thanks so much from this side. Over to you, Dr. Prashant and Dr. Shilpi.
Thank you, Dr. Vikas, for wonderfully conducting the last section of this quiz. So, guys, we are ready. So, till we are ready with the question, our backend office team is ready with the thing. Let me invite all the mentors who are today logged in with us for a small informal chat. Let me have a look who are the panelists today available. We have Dr. Inchara, Dr. Usha Bia, Dr. Grisha Ravindran, Dr. Preeti, Dr. Shinoy Shelja ma'am, Charulata, please log in. Please get your video in as well as audio on. Good. Dr. Purvasha, Dr. Anamika Agrawal, please join in for a small chat till we have ready with the results. So, Dr. Grisha, you are a postgraduate or you are a faculty or a mentor for the team? You are muted.
I'm a mentor, sir.
Oh, you look like a resident, senior resident, in fact. So, which team are you mentoring and which place you are from?
Sir, I am from Shankara Eye Hospital, Coimbatore. I'm a medical retina fellow here.
Okay.
I'm mentoring the team Ripples.
Very good, very good. Congratulations. Thank you for staying so strongly with your team and following us till the last part of it. Dr. Anamika is a mentor. I am aware she was even last time with her team. That's a commitment even from her.
Always with my team.
That's great, ma'am. So lovely to see you again. Who are the other people? Yeah, you have any comment, please?
Yeah, actually, I enjoyed the quiz, and this time they were kind enough, and I think they were very kind, very, very kind.
The quiz masters, you mean?
Quiz masters, yeah.
Okay.
Questions were also good, better than last time. Even I was able to answer, so I'm happy.
Okay, good. So we have Dr. Rajesh, Dr. Vijayavarshini, are you there with us? Dr. Charulata. I see Dr. Rajesh Joshi again, a young our professor. He doesn't look like a professor again. He is in fact a professor.
Following your footsteps, Prashant.
Thank you, dear. Thank you.
Yeah, very well conducted. I compliment all the presenters and those who have participated in the quiz. I do agree with Dr. Anamika. It was a bit easy this time. Last time it was very difficult. And our residents, they are very happy with the quiz. They must have joined today also, last time also. They joined and I asked them about the quiz. They were praising about you and all the presenters.
Okay.
It's a wonderful time, in fact.
Actually, I would like to add on, it is not only the quiz and the participation, it is enhancing the knowledge also as well.
Yes.
Giving them more confidence, sir. And I would say ki it is rather than easy, they were really kind to, it was a very good encouragement. Like my residents, there are two teams from my hospital. One is the junior most team, and yet they enjoyed. They said, I said we have to enjoy the process, irrespective. And the best part is that they are taking efforts. The quiz masters, they are taking efforts and explaining them. Suppose if I'm not able to answer, I there itself I get to know, what is the explanation. So Dr. Prashant, I really congratulate for the efforts, and I'm really really thankful for those mentors, for taking. It is not an easy task. When we set MCQs, it's not an easy thing. So it's hats off to them. I salute them
Thank you,
for
Dr.
taking.
Agarwal, for those kind words. In fact, I am sitting duck on the all the efforts taken by my quiz master. So what I do is a
Yeah,
small
yeah.
thing over
I
there.
salute them, each one of them.
So all my quiz
They were
masters.
so encouraging and they were so kind. In between that, some technical issues were there, and who will not feel to attend this thing? I congratulate
Thank
everyone.
you. Thank you. So Dr. Sonali is from your own town, ma'am. Okay, we have all the best of the only thing what we do differently is we get the faculties from across the country with having a love for quizzing. So that is the only thing which I offer on. So otherwise, I don't really
And I
need.
take this opportunity to see them, to get that encyclopedia knowledge ready-made in these 2 hours, and
Thank
that
you.
too comprehensive ophthalmology knowledge.
Okay. Thank you. Thank you for those kind words. This all words goes to Dr. Tamonash, Dr. Anita, okay, Dr. Vikas, Dr. Sonali,
All
Rupa.
the 5 quiz masters, yeah,
Yeah, thank you. Thank you.
very kind.
Thank you. Are we ready, Sai, with the results? So, Dr. Anita, how was your experience as a quiz master? So your questions were fantastic and your explanations were phenomenal. Even a person like me could understand a bit of ophthalmology. See, as we gray our hairs, we tend to forget the basic knowledge. We only know how to cut and achieve our whatever small clinical thing is. So you helped me in revising many of the things, all the quiz masters by your explanation. And that's what precisely all the people, mentors are echoing. And that is what we do differently. In the quiz, we expect everyone to explain the answer so that the students also get a learning process. So Dr. Anita, your comments, please.
Sir, it was fantastic, sir. Like very good experience, and we actually used to conduct a small quiz in our in our hospital with our own PGs, and we have done with all Aravind PGs like few months back. But this was amazing experience because we didn't like we were after seeing this we actually improvising in our hospital now, having an explanation slide and everything. And by this we are also learning new things. Like when we were exploring for new questions, we were also learning new things in even though we are like into this field for many years, but we also learned a lot while
The Arvind
doing
has
it.
been always a pioneer in it. Dr. Chandrasekhar from Coimbatore, he is a very dear
Yeah,
friend.
yeah,
I
yes, sir.
keeps on guiding
Yes,
me. Initially, he
he
was
was,
part of our quizzing team.
yes, he's an
So,
inspiration to all of us. Actually.
that is it. Tamunesh, what do you think? How was it for you experience? Kindly unmute. Huh?
Yes, sir. Yes, sir. Like previously, I have been a part of many physical quizzes, but online platform and in such a grand manner, it's for the first time. So I was also a bit nervous in the first set, but now in the second set, I was more comfortable.
Very, very true.
And I enjoyed all the questions. I was there throughout and all the explanation and everything. So it was great, sir. It was great.
Thank you. So, Dr. Sonali, she's just fresh. See, she's a senior resident. She must be knowing all the answers to all the questions. What say? Unlike us, you are so fresh from the post graduation. I hope the quiz must have been not that difficult for you as well. Unlike us.
So that's truly said. It's like it was quite easy because we keep giving international exams also. So it was like I have recently passed a year back. And I would like to mention that Dr. Anamika Agarwal madam was my external examiner in KM Hospital. So I'm so happy to see her here. And when she mentioned, I really loved it. So thank you so much, madam. And so it was an amazing experience for us to make these questions, find out the answers, make explanations. It is a learning experience for us also. And definitely it is a good academic experience for each one of us. It's nice to see so many participants, around 270 participants in total. So it feels very nice. Thank you, sir, for this opportunity.
Dr. Vijayvarshini, are you there with us? Dr. Purvasha? Okay, I think most of the faculties are there. Are we ready with the? Are we ready? How much time? Sai, are we ready with the score list?
A few more moments, please, Doctor.
Okay. Because we'll have to invite the students as well. Okay. Dr. Rupak, where are you lost?
I'm here, very much here only.
Acha, I thought you are seeing the patients in between the quiz.
I would love to do that always, because that is the only thing I can do. But I can't do so much of things like you. So in between patient, you can do everything.
No, for us.
And really, even with that also, so this program is a really big thing to organize it. And hats off to both you and Dr. Shilpi for doing it smoothly. It's not a matter of joke of coordinating with so many people together online. This is really a big thing, and big Q is a really big thing.
Basically, I'm pointing my finger towards who the credit should go to this lady who was seated besides me as a co-host. And now, since last 2 seasons, she has taken over the load from me. We initiated that time also. She was my small hand, one finger. Now she is the both hands of mine. So I don't have to look into all this finesse. She coordinates. She gets angry sometimes. Sometimes she gets frustrated. She's not getting the answers. Then I have to intervene and get all the people together. So it's a lot of HR management as well, because most of our quiz masters are busiest of the practitioners, and they are very accomplished ophthalmologists across the country. So the challenge is getting them, forcing them to be with us, because we do need them because of their own, they are having their own charm.
And you are master in that. You are master in that. You know how to catch out of people and then get it done.
So no, this lady was doing it all this. I was in the background.
I know. We were just discussing in VRSI during that only. And but again, it takes a huge amount of passion, motivation, time to chhodi dijiye. So without that, it is not possible. I mean, this kind of mammoth task is not a matter of joke. It looks like we are just attending this 1 hour program, and the task behind it is another days which is lying there. So I wish all the very success of this big Q. It should go to 1,000 level and go to the international kind of quiz.
No, we are doing well this time. We will be working hard. Last time also we had around 600 teams. So the every episode, depending on the postgraduates, their commitment in the evening, they come and go. Like last time we had a team of almost 345 or something. We had reached, so almost 700 students participated. This time we have saw. So there are some particular, and then it goes on increasing during the quarterfinals and semifinals as the crowd crunches, because we are going to have a best of 5. Means there are 8 preliminary episodes, out of which 5, the best of the 5 will be considered for their contention into going into the quarterfinals. So that is the reason. But yes, it is a task. Everyone, thank you for appreciating the task for us. But it is, in fact, the efforts, clinical efforts, rather, I should say, the academic efforts were taken by you. My only job was to get all of you together, and thank you for being with us. So let me see what Sai says. Sai, are we ready? Today, Sai, I think, is going a bit slow.
No, actually, no. There are multiple entries with the same number. So I'm combining that. That's taking a lot of time.
Okay. How much more time?
Another 5 minutes, please, doctor. Or a little less than that.
Or are we ready with the private practitioners, at least, that we can invite and have a chat?
No, even that there are duplicate entries. I'm combining that also.
Okay. So we'll wait for a while till then. Dr. Anita is there with us. We can have a small chat with her. She seems to be the faculty who has joined online. Oh, sorry, Dr. Anita is our quiz master. I'm sorry, I missed you. Who is that again? Vijayvarshini, Krisha, Rajesh. Okay. This is question answers. Can we declare it next time? So any category, if that is ready, we can declare.
In a minute, Doctor.
Okay. So, Dr. Sonali, what is your next interest after senior residency? Any specialty you are planning?
Yes, a fellowship I would like to apply. My interest is anterior segment. I'm looking forward to it.
Anti-segment, though it is such a small, has many special.
Paper.
Echo-refractive.
Yes, sir.
Okay, yeah, that's a big thing.
Big thing, yes, sir. So let's see how things work out.
It will work out. People, if you have a passion, if you have a will, and you are ready to go for it and spend time for it, you will make it.
Thank you so much, sir.
You will do it.
So I would like to thank you and Shilpi ma'am for this opportunity. And I really appreciate the amount of effort that Dr. Shilpi ma'am and you have taken getting us all together for the questions, the meetings, and the back-end work. I really appreciate both your efforts. Thank you so much, sir.
Basically, it is Dr. Shilpi who does after all the work I am sitting back nowadays on all these efforts she does. So I just compliments come to me bouncing through her. So I think all our efforts are basic needs to be lauded.
Yes.
No, it is a mammoth task to collect so many teams and then make them all uh, participate on such a huge platform. I think kudos to both of you.
No, the team
Congratulations.
effort is basically to some extent as we have grown in seasons. This is season 3. That is the reason. And most importantly, the microvision team is very steadfastly. They really go into medical colleges. They get the PGs enrolled. They encourage. And above all, the prize money is phenomenal. The 5 best mentors, 5 winning teams mentors are going to get 15,000. So that is another motivation. So the microvision has left no stone unturned. And more than Mr. Navneet and Ashok, it is their field force which really works very hard to have such a big participation. So Navneet, please, the compliment should go to the field force and not to you and Mr. Ashok.
You're right, sir. You're right. You're right. Yes, yes. It's our team effort, sir.
Excellent effort on everybody's part.
Yeah.
Congratulations.
Thank you, madam. Thanks a lot, madam. Yeah. We all are working as a whole team. I mean, under the guidance of Prashant, sir. Yeah.
So yeah, what is the status now? Yeah, good. So guys, we are ready here. Just hold on for a while. It's a dinner time. Many teams have already logged out. They know the results are going to get shared on the WhatsApp group.
I think the participants will have the appetite only for the results right now, nothing else.
Yeah, I know. Okay. So here we have a private practitioners category. So today's second runner-up is the phone number 7600024419. Congratulations. Are you there still with us? Just check. If you can, just raise your hand. That will help us. Then 8547562549 is the first runner-up in the private practitioner category. And of course, the winner in the private practitioner category with the prize money he will be getting is 5,000 rupees is 93150995559. So if you are there with us, you can log in for on a Zoom platform for a very brief chat. Now coming to
you can ask the attendees to post on the chat so that we can admit them.
Yeah, please post on the chat box so that we can ask you to join us on a Zoom platform. Yeah, so 8951831441 has already raised her hand. So she is second runner up that team, Shruti Nair. So let us see. Number 10 was 900332617 8145354488. Number 9 623868156. Then 8333068714. Yeah. So any participants who are there with us, please log into the Zoom platform immediately. We would like to see who were the good performers or the best performance in today's event, as well as the private practitioners. So this is the score, Sai, 42, 321 and all what is written besides them.
Yeah, that's the score.
Then I think our private practitioners have also done wonderfully. One of them has scored 48,028 points versus 42, the best in the PG category. So our all private practitioners are equally well read. That I am very happy about.
Whoever have raised their hands on the Q&A, please post a message on chat so that we can promote you.
तू इथलं झालं मी घेते ना खाली घेऊ ते बघ रेडी
Please mute yourself.
Dr. Shruti Nair has been promoted. Dr. Sanya Damija has been promoted. Dr. Rishabh Desai has been promoted.
So Rishabh Desai is in which category? Smooth Lizards have asked. Raise their...
So I'm the third one, I think, in the private practitioners group.
Okay. Sai, can you just unshare the screen so that we can have a small chat? I request all the quiz masters for today to have a small chat with the winners of today. Quiz masters, Dr. Anita, Dr. Vikas, Dr. Sonali, Dr. Rupak, Tomonash. Yeah. So Rishabh, you are in which category? Can you unmute yourself?
Sir, yes, sir. I think I'm the third one in the private practitioners.
Congratulations.
Category,
so you're second runner-up in a private practitioner category. Just can you tell me
yes,
short
yes,
about
sir.
yourself? Can you introduce yourself?
Sir, I work as a consultant in the Department of Pediatric Ophthalmology at Arvind Eye.
Your network is a bit poor. Can you be a bit louder?
Dr. Anita Madam happens to be one of my mentors here. Consultant in the Department of Pediatric Ophthalmology at Arvind Tirunelveli. Dr. Anita Madam is one of my mentors here.
Congratulations. So nice to see you, Rishabh. Now let us have a small...
Thank you, sir.
Madam, how do you feel to have one of your student here as one of the winners? I hope you have not shared any questions to him. Dr. Anita? Okay. Who are the other participants? Dr. Aparna case. Can you get your video on?
Yes, sir.
So you are in which category?
Actually, I'm working as a consultant in Chaitanya Eye Hospital, Trivandrum, sir.
Okay.
Orbit and Oculoplasty department.
Okay. So you are in private practitioner category. You were your number we couldn't. Yeah. I think your network is poor.
Yeah, yes, sir.
So you were number 2 or number 1?
Yes, sir. Number 2, sir.
Number 2. Wow, great. Congratulations. I was in Trivandrum last week. It was quite warm and humid.
Thank you, sir.
Thank you. Thank you. Thank you for
Yeah,
the other side.
yeah, yes, sir.
Thank you.
No, I was there in KS.
Okay.
Sir.
Your network is a bit poor. Your words are coming quite broken.
Richard.
Richard, okay, okay. Yeah, we have other people. Akshika Dhamija. Hello.
Yes, sir.
Can you unmute yourself and also get your video on?
Yes, sir.
Yeah. On which number were you?
So we were second.
Wow, great. So where are you from? Can you just introduce both of you, your team members?
Sir, I am Dr. Akshika Dhamija from Dr. SN Medical College, Jodhpur.
Sir, I'm Dr. Vineet, third year resident, SN Medical College, Jodhpur, Rajasthan.
Very well played. Very well. And who is your mentor?
Dr. Arvind Chauhan, sir, head of department of our institute.
Very good. Very good. Congratulations, and do congratulate on our behalf. But this is not the end. This is just the beginning. Remember, it is the best of the 5 which will be considered. So keep playing. Congratulations once more.
Thank you. Thank you, sir.
Very good. Better. Saib, do we have other teams here? Dr. Shruti Nair is there with us. Dr. Shruti, can you unmute yourself? Yes, Shruti. You are muted. You are muted. Louder, louder.
Good evening, sir. I think my audio is a bit low.
Okay, where are you from?
I'm from Jipma, Pondicherry, sir. I'm a
Oh.
second-year resident.
Okay, where is your team member?
She was a little busy today, so she couldn't.
So you came number 3 or number 2?
Number 3.
Number
3, sir.
3. Well played, all alone. Huh? Singular effort. Great, well played. And do tell Kasturi ma'am and all my regards. Okay?
Yes, sir, definitely.
Please, please. Bye-bye. Best of luck. I think we are through. I think, Sai, we are through. I believe anyone else has joined in? Sai?
No, doctor.
Okay, fine. So it's time for us to wind up. Let me once more thank all the quiz master, Dr. Vikas, Dr. Anita, Dr. Sonali, Dr. Rupak and Tamonash for wonderfully creating questions which were not only informative but also interesting and also a learning experience to most of our viewers. And my sincere thanks again to Microlabs as well as the Numerotech team for doing all this back-end work. And should I thank my co-host? I think she deserves to be thanked on my behalf. So thank you, Dr. Shilpi, for being with us and helping us out with this, all the effort. And once more, all the viewers, thank you. And all the mentors for helping your team to lead that chart and all those things. So we will be meeting again on next Wednesday. That is going to be the 20th of December, again at 8 p.m. same time. Till then, it is time for us to take a bye. And so have a great day, a great evening, and have a good food and adequate rest and get ready for the next episode. Till then, bye-bye from all of us at Big Q. Thank you.
Thank you.
More.
Thank you.
Thank you.
Bye. Thank
Bye.
you.
Bye. Good night.